My name is Jae-yoon Kim, and today's case is upper premolar implant insertion and immediate loading. The patient has a congenital missing on number 14 tooth, and he treat the orthodontic treatment, and then he need an implant placement to come to my clinic. So I insert a regular size fixture on the congenital missing site. There is a small buccal bone loss, but there is no problem to insert the implant. I use the H incision. That means preserve the papillars and 1 to 2 millimeters preserve the papilla, and with blade and little bit palatal side incisions. After do the incision, the shape of incision is H. That means H incision. I usually use the Molcuras and P24G peroxide elevator because the beak is a little bit small. So in such a small flap, these instruments are very useful. So after I elevate the flap, there's a small defect on the buccal area. I drilling with the point drill, and then use the Lindemann drill to guide the path and the position. I use the first twist drill. If you are beginner, you should use the first twist drill with half of drilling, and then with a parallel pin, you should check the path and position. After use of first twist drill, I insert the parallel pin to check the path. Check the path with the meter, and the path and the position of point and first twist drilling is relatively good. After that, the sequential drilling is easy. Just insert the large size of drill with the same positions and same path. Insert the fixture on the prep side. You should use the engine with 90% of insertion, and then use the torque wrench. Use the torque wrench and feel the insertion torque and the depth control. The fixture should insert into the bone about 1 millimeter below the bone level. Use the depth gauge and check the IS value is relatively good. After checking again, because this case is immediate loading, so I insert the abutment, narrow healing abutment. You should connect the abutment with high torque, about 30 newtons torque, to prevent micro movement of the abutment. And I use the figure of 8 suture to adapt the flap to the abutment. I use the Gore-Tex silk suture materials, but torque control is a little bit difficult when we use this suture. So I think nylon is better than this silk to tension control. With the sewing motions, I control the tensions and make a knot. Because major side of flap is a little bit, there's a space between the major side, so I use one more single interrupted sutures and get a tension to adapt the flap more closely to the abutment and make a knot. Then use a rubber dam to prevent metal debris and other material to insert the surgical site. After correction the abutment, and insert a Teflon tape into the hole. Then use a direct resin with a direct technique. If you have a 3D printers and intraoral scanner, you can print out the temporary crowns, and you can use other techniques like shells or other things. It's almost same procedure when we prep the crown and then make a temporary crown. Insert and get out, and adjustment going on and on. After polymerization of the direct resin, adjustment with denture bar. The point is slight contact on centric occlusion and no contact on lateral excursion. That is the key of immediate loading. And check. There's a little bit contact on lateral excursion and adjustment. And cementation is used with GPC, the final cementation materials, because micromobilities of temporary crown make the terrible disaster, so use the GPC or final cementation materials. There's a result. After 1 week, after stitch out, and then 3 weeks, there is slight recession of gingiva, of course, but no problem. Thank you for your kind attention.